Good morning and good afternoon, everyone. We're just going to wait a few moments as the system joins in people who are in the waiting room, and then we'll get started. All right. Good morning and good afternoon. My name is Patrick Sullivan, and on behalf of my co-host for this series, Dr. Ken Mayer, I'd like to welcome you to today's Antiretrovirals for Prevention Symposium session. For those of you who haven't attended before, I'll just say a quick word about the format. We are going to just move straight into, after brief introductions, move straight into a presentation that will take up most of our time today, but we will leave some time for discussion. And so I'd like to encourage you, as you think of questions, to put them in the chat, and we will have a guided question and answer session with our presenters today at the conclusion of the talk, and we'll draw from questions that you've put in the chat. Or if there's something you want to ask in person, you can also just say, I'd like to ask a question, and I'll call on you. So I'm going to be brief in introducing our speakers today because I know that they have a lot of great stuff to present, and because I think they're known to many of us, but I'll quickly welcome Dr. Connie Kellum, Professor of Global Health Medicine and Epidemiology, and the Director of the International Clinical Research Center and the CFAR at the University of Washington. Welcome, Dr. Kellum. Dr. Jennifer Velosa, an Assistant Professor in the Division of Global Health and ID-Epi. And Dr. Velosa works in the field of global mental health and the intersection with HIV and STI prevention for adolescent girls and young women. Welcome, Dr. Velosa. And Dr. Sinead Delaney-Morletwe, who is a research professor and director of the Wits RHI Professor of Global Health and Infectious Disease at the University of Witwatersrand in Johannesburg. Her interests span the intersection between sexual and reproductive health and infectious diseases in adolescent girls and young women. So what a fantastic group of colleagues today to present. And the presentation is titled PrEP in Young African Women, Lessons Learned. And I think we'll give it to Connie to kick things off.
Thank you, Patrick, and thanks for the invitation. As you'll see, this is really the work we're presenting today embodies team sciences. This is not work that any one of us could have done alone, I think, and there's a large group of people that have walked this journey with us the last, I don't know, how long is it, 10 years since we knew that PrEP worked, to see whether or not it could work in terms of effective use among young African women. So I'll just introduce briefly the questions that we had, and I think some of these questions dated back to almost 10 years ago, when some of the efficacy trials did not demonstrate efficacy of FTC TDF in young African women. So one of the earliest questions, will young women take it? Do they want it? Do they recognize their need? Then we had questions as we started the period of doing early demonstration projects and anticipating that it would be a lift, and that the reason why we didn't see efficacy in a couple of the trials was due to adherence. We wanted to learn about how do we support adherence and persistence with oral PrEP in young African women. As we started doing some of these demonstration projects, we also realized you can't just live in a siloed world, especially for populations who are sexually active. And we started uncovering a very high burden of STIs, and we'll touch on that. And then as we realized, as we kind of knew, I think from the beginning, that a pill a day is not an easy intervention or feasible for all populations, that we wanted longer acting PrEP. And so we were very excited to see both the early data from the dapivirine ring, as well as the very high efficacy for CAB-LA, and we'll touch on that. And then as we do now, enter a period where we have choice of options, we'll talk about how do you provide those choices? How do you help young women make informed choices? So these themes will run through the work that we'll talk about today. We'll start off with Dr. Jen Veloza, who will be talking about Prep Smart, which was a stepped approach to improving oral prep for African young women, with the idea that one size doesn't fit all, and maybe we could figure out who needs more support and find interventions that work for them. Secondly, I'll give a high-level overview of some encouraging data coming out of an ongoing prep study called Insight. And then lastly, but not leastly, that didn't sound right, Dr. Sinead Delaney-Moretley will talk about CAB-LA and the important findings from HPT in 084 and the open label extension study. So with that intro, I'm going to turn it over to my colleague, Dr. Jen Veloza. Oops, danger, I'm advancing the slides. Okay, Jen, take it away.
Awesome. Thanks very much to Patrick and others for the invitation to present today. And as Connie mentioned, I'll start us off by talking about some findings from our sequential multiple assignment randomized trial, which sought to evaluate adaptive PrEP adherence support interventions for adolescent girls and young women in South Africa. Next slide.
Oops, I have to stay focused.
Yeah, you have a big job, Connie. So I'm presenting this work on behalf of our study team at the Wits Reproductive Health Institute in Johannesburg, and you could see many of their faces here. Next slide. So HIV pre-exposure prophylaxis, or PrEP, as you all know, is a highly effective HIV prevention strategy that's currently being scaled up worldwide. And there are about 2.2 million people who've initiated PrEP across the globe, and adolescent girls and young women are a key population for PrEP delivery. But while PrEP uptake has been relatively high among young women, challenges exist with PrEP adherence and continuation in this population. Recent PrEP implementation projects in Southern and Eastern Africa have reported that while around 90% of young women initiate oral PrEP, less than 50% actually persist on oral PrEP through about 1 month, and only about 20% adhere on PrEP through 9 months. So we're seeing pretty big drop-offs. A number of different PrEP adherence support interventions have been developed for young women, and these include things like text messages for support and reminders, in-person or virtual adherence clubs, person-centered counseling, and feedback based on levels of PrEP detected in pharmacologic samples, also called drug level feedback. But these approaches have really been evaluated largely as standalone interventions, and there's been a lack of evidence on what works best to meet the diverse needs of adolescent girls and young women. So as a result, many of these interventions are provided simultaneously in big packages and to populations irrespective of need, which can be very time and resource intensive. So we think that PrEP implementation would benefit from differentiated and layered adherence support strategies, things that provide, say, light touch support for a majority of adolescent girls and young women, and then reserve more intensive support for just a subset of clients who might benefit from more frequent counseling or tailored adherence support. Next slide. So we sought to contribute to PrEP implementation by testing a stepped model of PrEP adherence support strategies for South African adolescent girls and young women. And our primary research question was to understand what is the optimal sequence of combination adherence support interventions that might be most effective for promoting oral PrEP use in this population. Next slide. So the PrEP Smart study began in May of 2019, and it's led by Connie and Sinead and myself as the project director. And it gets its name because it's a type of study called a SMART design, which is an acronym, and it stands for Sequential Multiple Assignment Randomized Trial. Next slide. So to orient you to this trial, I want to first talk about what a SMART design is and why you might conduct one. So we know, as I just mentioned, that not every young woman has the same needs around PrEP support. And also their needs might change over time. What they need at enrollment might be different than what they need at month 6. So it would be potentially a waste of personnel time, and clinic resources to offer everyone who walks into an HIV clinic the same package of PrEP support services. And that probably wouldn't be very effective for everyone either. So instead, we can try to move toward adaptive interventions using individual factors like disease severity, patient preferences, side effects that they might experience, to try to adapt our intervention to patients' or clients' needs over time. Next slide. So SMART designs are randomized trials that really give us data to inform those adaptive intervention designs. And specifically, they can help us identify decision rules about when and how we might want to scale up our intervention services, along with things like what's the ideal type or dose of interventions that we're providing, and what's the optimal sequence of interventions. So we can try to create interventions that are more tailored to young women's needs and are also more resource efficient for a health system. Now you start a SMART design the same way you would any other randomized trial. That's step one here. You would recruit your participants and then you'd randomize them to interventions and you'd follow them over time to see how they respond. And that's typically where we might stop with an RCT. But with SMARTs, we have a series of additional steps. So we often like to see how folks do at some predefined time point. And then, for example, for those who are doing well, we might just have them continue on with their first intervention. So that's step 4A on the figure here. And for those who maybe don't respond well according to some pre-specified decision rules that we set, we could then re-randomize them to say new interventions or step up their care in some way. And that's step 4B here. And this is just one example of what a SMART design might look like with steps 4A and 4B. But there are many different options for what you can do with folks who do or don't respond to those initial interventions. Next slide. So for our SMART study, we recruited young women in Johannesburg between the ages of 18 to 25 years who were eligible for daily oral PrEP and had a phone that could receive WhatsApp and SMS messages. Next slide. So all enrolled participants started by receiving one of two light touch mHealth options, two-way SMS messages or WhatsApp support groups. In the SMS intervention, the participants were asked weekly whether they were doing well, and those who said no or who didn't respond to those messages received a phone call from a clinic staff member. The WhatsApp groups had about 20 to 40 participants in each of the groups, and also a staff member who kind of moderated the groups. And the groups were really responsible for discussing issues related to HIV prevention and other topics in their lives. So those are our primary interventions. Those are kind of our light touch interventions for everybody. And then young women who had difficulties with PrEP after 3 months received more intensive interventions. And these were counseling-based approaches, plus their original mHealth intervention that they got to keep receiving. So here we had either drug level feedback, which was when we provided targeted messaging and corresponding Wi-Fi signals for high, medium, and low PrEP adherence based on PrEP measured in dried blood spot samples. We also had a monthly counseling intervention that included client-centered counseling with modules on depression and stress, healthy relationships, stigma, and other topics. And all participants also received standard of care PrEP adherence counseling based on South African national guidelines. Next slide. So enrolled young women to either of those initial mHealth interventions, either 2-way SMS or WhatsApp, and they completed study visits at months 1, 2, and 3. Those who were non-responders to the primary intervention at month 3, which we defined as having either low PrEP drug levels measured via tenofovir diphosphate or missing a PrEP refill, they were re-randomized to either of those more intensive counseling interventions, drug level feedback, where they had quarterly study visits, or monthly problem-focused counseling, where they came in every month. And those who responded to their initial intervention just continued to receive either the SMS or the WhatsApp adherence support. And our primary outcome was PrEP adherence at month 9, which was assessed using tenofovir diphosphate levels. Next slide. So we conducted 3 primary analyses. In the first, we explored the effect of those primary mHealth interventions on high PrEP adherence at month 9. And here we defined high PrEP adherence as having tenofovir diphosphate levels in DBS samples of 700 femtomoles per punch or more. In our second analysis, we explored the effect of more intensive interventions, the monthly counseling or the drug level feedback, on PrEP adherence at month 9. And here we restricted the sample only to non-responders to the primary interventions who actually received these secondary interventions. Next slide. And finally, we explored the optimal PrEP adherence support strategy for young women by looking at the probability of high PrEP adherence across the 4 embedded dynamic treatment strategies in this study. And those included these 4 boxes that you see here. First, offering 2A SMS, and then if you're a responder, you just continue. If you're a non-responder, you get layered on drug level feedback counseling, or you could first offer 2A SMS and then layer on monthly counseling, or first offer WhatsApp and layer on either drug level feedback or monthly counseling. Next slide. So we screened 401 adolescent girls and young women and enrolled 360. And half of these were assigned to the 2A SMS arm and half to the WhatsApp arm. At month 3, 91 participants in the 2A SMS arm and 105 participants in the WhatsApp arm were responders. And these you can see in the 2 orange boxes on either of the far sides of the screen. 85 participants from the 2A SMS arm and 70 participants from the WhatsApp arm were non-responders at month 3 and were subsequently re-randomized. And these are those 4 boxes in the blue in the middle of the screen. And retention was between 65 to 88% across all of those groups at 9 months. Next slide. So the median age of participants at enrollment was 21 years. And in the 3 months prior to enrollment, 36% reported never or rarely using condoms, and 24% reported transactional sex. 31% were diagnosed with an STI at enrollment, and about half had experienced intimate partner violence and depressive symptoms. Now, the figure on the right is showing PrEP continuation and adherence over time in our cohort. And you can see that among the 360 participants enrolled, looking at the orange bars, which show you retention and continuation at the 2-month visit, 78% were retained at month 2, 94% of those continued on PrEP at month 2, and 62% of those had high adherence to PrEP at month 2. Now, when you look at the black and gray bars, which show you retention, adherence, and continuation at month 9, you see that 78% of participants were also retained by month 9, of whom 89% persisted on PrEP, and 27% of those had high PrEP adherence at month 9. Next slide. So now I'll talk about the first 2 primary analyses, and let's focus on the bar chart on the left side of the screen first. So in our first primary analysis, we explored the effect of our mHealth interventions on PrEP adherence. At month 9, 20% of participants in the 2A SMS arm and 18% of those in the WhatsApp arm had high PrEP adherence, and we did not observe a statistically significant difference between those 2 arms. Now, looking at the figure on the right side of the screen, we then explored the effect of our 2 more intensive counseling interventions on PrEP adherence, and we restricted only to the 155 re-randomized participants. At month 9, 5% of those in drug level feedback and 4% of those in the monthly counseling arm had high adherence. And again, this difference was not statistically significant. Next slide. And lastly, we found that the probability of high PrEP adherence at month 9 ranged from 24 to 27% and did not statistically significantly differ across those 4 embedded dynamic treatment strategies in our study. Next slide. So I want to also just talk briefly about a qualitative sub-study that we did as part of PrEP Smart. We conducted interviews with a purposive sample of 48 adolescent girls and young women, and we stratified the sample by PrEP adherence levels and randomized arm to ensure that we had mixed representation in the interviews. We conducted serial in-depth interviews at month 2, 6, and study exit to try to understand participants' perceptions of their primary and secondary interventions, and if those changed over time with, say, participant burden or fatigue. We also conducted additional interviews with clinic staff and key informants to ask about their perception of the scalability of the intervention packages. All interviews were recorded, transcribed, and translated into English, and we used two different types of analysis approaches, which sort of depended on our primary research question for a given analysis, but we either coded using deduce or we used rapid ethnographic methods. Next slide.
Oops.
Yeah. Perfect. So participants generally liked both of those primary mHealth interventions. They reported that WhatsApp provided a means of peer support, which was great for them, and SMS provided a different type of support. It was perceived support from healthcare providers and clinic staff. So for example, one participant in the WhatsApp arm said it's useful because it doesn't only help with prep, it helps with any difficulty you have. If you can't do it yourself, you have people to talk to, people that have experience in it, and they can help. And then a participant in the SMS arm said, I feel like they being the clinic staff, care about us and they follow up to find out if there are any side effects. Barriers to the SMS and WhatsApp participation largely included issues with the phones and network, things like phone malfunctions or power outages. And when participants were asked which of these interventions they would prefer in the future, the choice was really related to their personality and their lifestyle largely. Participants who wanted more privacy and didn't really feel as great of a need for social support generally said that they preferred just having two-way SMS. And those who didn't really want regular SMS reminders, they thought the weekly messages would be a nuisance. They wanted more organic opportunities to talk to peers. Those folks preferred the WhatsApp messages. The two second-line counseling interventions were also both generally acceptable and really provided a platform to encourage young women about their PrEP use and give them opportunities to reflect on HIV risk. But the biggest barrier to both of these interventions was returning to the clinic regularly and also delays in results for getting drug level feedback counseling for folks in that arm. Next slide. So in conclusion, in our SMART design of adaptive PrEP adherence support, we did not detect significant differences between either of our primary or our secondary interventions or across those four treatment strategies. And that tells us that each adherence support strategy likely had a similar impact on PrEP adherence, and PrEP programs might be able to just adopt approaches based on client preferences and scalability in that clinic location. However, we did not compare interventions to standard of care alone, and it was really challenging to re-engage non-responders after 2 months of PrEP use, which resulted in lower retention in those more intensified intervention arms. The SMART design offered a really novel way to look at questions of differentiated PrEP adherence support, and we found that it was feasible to implement and to explain to young women. Now, among our cohort, we saw that 25% had high PrEP adherence at month 9, and that's actually a bit higher than comparable cohorts, despite the fact that this was going on during, in some cases, the height of the COVID pandemic. And our interventions may have collectively had a positive impact on PrEP adherence given this, or it's possible that background rates of PrEP adherence might be improving in this population as PrEP just becomes more common in South Africa for young women. Now, despite this, our data suggests that individual level adherence support interventions are likely not enough to overcome structural barriers to daily oral PrEP use for this population. And as Connie mentioned at the beginning, and we'll hear more about from Sinead, future research is really needed to consider introducing choice of long-acting PrEP products and those based on client preferences and challenges to adhering to daily oral PrEP. Next slide. And thank you very much. I'm happy to take questions at the end.
Thank you, Jen. That was great. You summarized kind of the why and the how of a SMART design really, really clearly. So thank you. That was great, and look forward to the discussion about that. I'm going to switch gears now and talk about the Insight cohort, which we designed on the heels of the FDA hold of the monthly islatravir prevention trial. And just for those who haven't followed this closely, that in July of 2020, One, we were activated to do a trial. There were parallel trials in women and MSM in the Americas and other international sites. And in the women's trial, which included US and African countries, we were funded by the Gates Foundation in a partnership with Merck to enroll women from 21 sites in 6 African countries. 15 sites were in South Africa, and then 1 site each in Eswatini, Kenya, Malawi, Uganda, Zambia, and Zimbabwe. And we all had a huge surprise and wake-up call in mid-December 2021 when the FDA put a hold on islatravir due to data that were emerging from a trial of islatravir as part of combination treatment that showed significant declines in lymphocytes. So we couldn't enroll any additional participants in the time since then. We've continued to follow those who were in, we had roughly about 700 something women in the African sites who had been enrolled and randomized. They were continued close follow-up, but we were not able to enroll any other women or to do mechanistic studies. So in January of last year, we pivoted from the efficacy trial and received approval from the Gates Foundation, which we really appreciated, to implement something which we called the Insight cohort, which was designed to, in these same sites, to study oral PrEP uptake, preferences regarding PrEP formulations and delivery, as well as adherence. So it was a big effort, and really appreciate everyone's work on this, because we basically launched a new study in about 7 months. And that's not a trivial thing to do with 21 sites with multiple translations and IRBs. And then in 3 months, a little over 3 months, enrolled a cohort of 3,000 women. So this study is still ongoing, but I thought it would be useful to explain a little bit about this and what we are learning and will continue to learn, so that you can stay tuned. And really, we had a handful of objectives. One, which was to use the recency assay to estimate HIV incidence from women who test HIV positive at enrollment. And this will be helpful for future trials, non-placebo controlled trials, to get a counterfactual estimate of HIV incidence in the cohort that's enrolled for a trial of a new agent compared to a active comparator. Secondly, to look at PrEP uptake and persistence among adolescent girls and young women. And as Jen just described, from a number of different studies, we know that there's tends to be high uptake, but then fast drop off. And we wanted to understand, again, in a very diverse cohort amongst women enrolled from 6 countries, what that trajectory looked like, and whether or not we could understand risk factors for non-persistence. Thirdly, we wanted to understand bacterial STI prevalence and incidence, as well as high-risk HPV prevalence. Fourthly, we wanted to look at what are, in this cohort of women who are being offered oral PrEP, they weren't required to take it, what were their preferences for PrEP formulations? And we did a discrete choice experiment, both at enrollment and month 1, to see whether or not those preferences changed after they had a month's experience with oral PrEP, and then their preferences for where and how to receive PrEP in terms of clinic versus community-based delivery and types of HIV testing, which will show you what those discrete choice experiments looked at. And then lastly, at month 6, as women are being exited and referred to public health clinics, we're evaluating a decision support tool that to see whether we can help young women make informed choices. And you'll hear more about that decision support tool from Sinead in the last part of the presentation. So these are preliminary data, because as I said, this is an ongoing cohort, and we finished enrollment in December 2022. A little over 3,300 women were screened. Almost 3,100 were enrolled, with almost 2/3 being less than 25 years of age. We had 145 women who tested positive for HIV at screening, and we are currently doing the recency testing to understand what the predicted incidence would be in this cohort based on what proportion are recently infected. We had very high PrEP uptake, 96% at enrollment, and then a substantial proportion of those who didn't take it at enrollment decided to take oral PrEP after enrollment at months 1 or 3. We've had high retention with 90% retention at month 3, and this is with relatively light touch efforts for retention. So I want to really say, I find these data encouraging combined with the high adherence, and we are using the urine tenofovir assay that Monica Gandhi and team developed, and based on our preliminary data, and we're still QCing this, and so we'll have more complete data in the next few months, but it looks like adherence is about 80% in this assay that measures tenofovir intake in the past 4 to 5 days, which is higher than prior cohorts. And again, this is in a fairly real world implementation of oral PrEP. So I find that very encouraging. In terms of STIs, we in this study are finding very high STI prevalence and incidence, and this is not new news, but I feel like we need to keep saying it because we need to do something about it, that almost 1 in 3 women have at least one STI at enrollment. About 1 in 5 had chlamydia, 7% had gonorrhea, 6% trichomonas, and 5% syphilis. And the syphilis prevalence is considerably higher than what we've seen in prior PrEP demonstration projects in this age group. And in the subset for whom we have data, which is only about 1/5 of the cohort, about 1/5, that 23% have an STI. So again, we are treating those women who have a bacterial STI at enrollment, but we're still seeing high incidence. So it's just a reminder that we really need to think hard and do something about the STI burden in African young women. The DCE that we're doing is looking at attributes of PrEP, the kind of, do young women prefer oral pills, small or large? Islatravir would have been small, like a size of an aspirin. We all know that FTC TDF is not small, it's quite large, taken daily. An injection taken every 2 months, like Cabalea, an injection taken every 3 months, if we can space out the dosing as some of the early data suggests, or lenacapavir type dosing every 6 months. Dose forgiveness, which is a hard thing to explain in a cartoon format, but whether or not how tightly women have to get refills or an injection in terms of the different formulations, as well as reversibility. How long does it stay in your body? Is it associated with weight loss or gain? And we also added a question that tried to get at this issue of using a small ARV-based approach versus broadly neutralizing antibodies. And again, I'm not sure how all that translates in this format, but we'll hopefully get some useful data. And at month 3, we're asking about where would women want to get PrEP? In a clinic, a pharmacy, mobile van? Would they prefer to take it at home or in clinic? A question relevant to if we get long-acting oral regimens, could it be DOT or should it be something self-administered? Would they prefer one or the other? Packaging, blister packs, pill bottles, privacy of product storage, which we heard a lot about in the days when we were sending women home, and still are, with 3 bottles of 30 tablets approximately for daily oral PrEP. Not a trivial thing if you live in a tight space with limited storage options. HIV testing, would they prefer to do an oral self-test versus blood cell test at home versus be tested as they're familiar with a rapid blood test in clinic, and their willingness to pay. So stay tuned. As I said, we're still underway and we very much look forward to learning from these. And lastly, I just want to end by acknowledging the incredible group of investigators from many sites in Southern and East Africa. This was a hard thing to go through a FDA stop and then to pivot, but the teams have done an amazing job and really feel very, very fortunate to work with them. And now we'll turn to cabotegravir and hear from our colleague Sinead Delaney-Moretley about the lessons around efficacy, adherence, and acceptability with CAB-LA.
Thanks very much, Connie, and thanks very much for the opportunity to share some of these insights with you. Really, just to kind of start, cabotegravir is one of the first of the long-acting PrEP agents that have demonstrated safety and efficacy based on two large phase 3 trials, HPTN 083 and 084. Both of these studies were stopped prematurely in 2020 for efficacy. In HPTN 083, they observed a 66% reduction in HIV infections in cisgender men and trans women who have sex with men in multiple countries. And then 6 months later in HPTN 084, we observed an 88% lower risk of HIV in women randomized to cabotegravir compared to Truvada. These data were then updated 1 year after unblinding, and the basically reductions in risk were shown to sort of persist out to 1 year post unblinding. And generally, the idea, we've had the belief that long-acting agents likely confer an adherence advantage, particularly in people who find it difficult to take a pill a day. Next slide. So it was useful to see that hypothesis confirmed really initially from some of the qualitative data. So we conducted a qualitative sub-study in 4 sites in HPTN 084, which included 63 participants, the majority of whom were single, and about 1 in 5 identified as sex workers. And what we saw from this is that women really preferred a discreet, convenient PrEP method, especially if they had busy lives and couldn't adhere to daily pills. And in fact, what we tended to see is people who had sort of higher risk, less stable environments were more likely to express a preference for a long-acting method. Next slide. So following the unblinding of these 2 trials, we went through a period where at the instruction of the DSMB, all participants were unblinded, and then we had to develop a protocol amendment, which really created the opportunity for participants to be offered open label cabotegravir, and this protocol amendment is known as the open label extension. So there was a period between the unblinding and the open label extension where participants were continued in follow-up, but on their allocated arm. Next slide. And the goals of the open label extension there are a number of them, including sort of ongoing assessments of efficacy and safety of cabotegravir, but also importantly to really understand acceptability by understanding some of these measures in the PrEP cascade of uptake, continuation, and discontinuation, and then better characterization of individuals who do seroconvert, as well as additional information on the safety and pharmacology of cabotegravir with active dosing in pregnancy. Next slide. So really just to explain the design, next slide. In the blinded period, participants were randomized either to active cabotegravir and a placebo pill, and there was an oral lead-in followed by injections 4 weeks apart for the first 2 injections, and then every 8 weeks. But then in the open label extension, participants have an opportunity to choose which agent they wish to receive, either cabotegravir or Truvada. And so for some people, they may be initiating cabotegravir because they were on the Truvada arm initially, and there are a number of steps to do that. And the open label extension has just been extended to allow follow-up for 96 weeks. Next slide. So with the transition to the open label extension, we have seen that about 82% of eligible participants actually accepted the open label extension, and the reasons for acceptance really related to participants who had relocated or were lost to follow-up, but also interestingly, people who had been on study for 4 to 5 years and actually their risk had changed, and so it was reasonable that they no longer wanted to continue in the study. The big question has really been, which product did participants choose? And what we've seen is just over 3/4 of all participants have actually accepted cabotegravir. And what has been interesting to learn is that people choose the agent really based on 2 big issues. The first is that those who have a fear of injection, side pain, or discomfort with needles tend to opt for TDF-FTC. But then there is a group that definitely has a preference for a discrete, convenient method which avoids any inadvertent disclosure and the stigma associated with daily pill taking, and they have opted for injectable cabotegravir. In a subset of participants who were pregnant or who have become pregnant, it's interesting to see that those preferences go both ways. So there are individuals who are concerned about safety in pregnancy, and those concerns were influenced to some extent by the concerns about the use of dolutegravir, periconception dolutegravir, and sort of the conversations that we had about that issue when it emerged sort of mid-trial. But then there are also participants who've really embraced the idea that cabotegravir is effective for preventing HIV infection, and so they have strongly opted to use cabotegravir during pregnancy because they desire a sort of HIV-free pregnancy outcome. And you'll see in the slides that Connie presented, one of the attributes that we've been interested in is whether people prioritize reversibility at all. And just to say that in the discussions that we've had with providers, this is not something that comes up when 084 participants are choosing their preferred PrEP method. And this may be because they're a unique population which has had many years of counseling about injectable cabotegravir and have understood the implications of the so-called pharmacokinetic tail. But it's interesting that this is not an issue brought up by users and also doesn't seem to have featured strongly in provider discussions, and may be something that we should be aware of as we move into programs. I think the other thing we've learned about what influences choice, and it I think reinforces what we've learned from oral PrEP, is that partners, family, and kind of others in people's social network are really influential to decisions and may make it much easier, for example, for some participants to choose to continue taking oral TDF, while for others it very much means choosing a discrete method where they don't have to disclose their PrEP use. And what we learned in 084 is that decision support tools are really helpful for helping providers to have discussions with participants about the range of risks and benefits of each method, and how they can think about sort of the aspects or the dimensions of that choice. Next slide, please. So some people have asked, well, what do we know about the acceptability of cabotegravir in younger age groups? And this is really just to highlight data that Dr. Sybil Hosek presented at CROI this year, which was the results of HPTN 08401 as a single-arm study in adolescents under the age of 18, looking at the acceptability and pharmacology of cabotegravir in this age group. And what's important to learn is that cabotegravir was found to be safe and tolerable in this group. There were no discontinuations due to adverse events. Adherence to injection visits was exceptional, with 100% of injection visits completed. And young women or adolescent women in this age group expressed interest in ongoing use. And in fact, the majority, more than 90% of participants in the sub-study subsequently chose to continue cabotegravir in the open label extension. So this is a method that has both efficacy, but also is favored by a younger population. So I think sort of one of the, as we see an expanding array of, sorry, next slide.
Sorry, got ahead of you.
So I think one of the things that has that we are incredibly aware of is, as the range of PrEP options expands, we need to be sure that we're offering a choice of PrEP agents to users in a way that their values and preferences are taken into account when a PrEP method is recommended. And this has led us really to consider the potential of a decision support tool, which could overcome multiple both client and provider barriers when offering PrEP choice, particularly in settings like in sub-Saharan Africa, where resources are constrained, including provider time, provider skill, provider knowledge, and particularly as we introduce new methods where generally there's very little knowledge about these new methods. And these sorts of decision support tools may overcome some of these barriers and facilitate basically better PrEP choice, which may lead to better PrEP persistence and continuation. Next slide. So we developed with Connie, we developed a PrEP decision support tool. It was based on a decision support tool used for contraception called MyBirth Control, which was evaluated in the US in a cluster randomized controlled trial and was shown to have a number of positive impacts, including improved contraceptive counseling, informed decision-making, but also knowledge of methods. Providers found the tool useful because it could help them allocate time better in consultations. And they also, providers also reported that users appeared to be more informed if they were exposed to the tool. So there were a number of sort of qualitative benefits, although there was no effect on 7-month continuation of contraception. Nevertheless, we thought that the idea of a decision support tool would be useful in the HIV prevention space. And so using very much the same development approach as was used for MyBirth Control, we developed a decision support tool for HIV prevention, which included modules on PrEP, and then through an iterative process, which included also user input from potential users in South Africa and Kenya, we developed the MyPrEP decision support tool, and subsequently evaluated that in a randomized controlled trial in downtown Johannesburg in an urban primary healthcare setting. Next slide. So the primary outcome or endpoint of the decision support tool evaluation was PrEP uptake at enrollment. But what you can see is that uptake was very high in both groups. In the decision support tool, 97% of potential users accepted PrEP, and 94% in the comparison group who were exposed to a general health information website. And so there was no difference in uptake. Next slide, or next click again. But what was very striking was the result for PrEP continuation at 1 month, because although continuation was low in both arms, it was very consistent with what we had seen in other PrEP cohorts at around the same time. But what we observed was that the decision support tool essentially led to a 2-fold increase in PrEP continuation and at month 1. And so this kind of suggested to us that this may be a useful tool and may suggest that potentially those exposed to the decision support tool are making better choices about what PrEP methods might suit their lifestyle. Next slide. We also did some qualitative work to understand participant perspectives of the decision support tool, and the feedback was generally that users liked the tool because it provided them with a better understanding of their options. It answered questions that they had, but also those they hadn't anticipated. it provided information about how PrEP works. The language was simple. It had memorable content, and they felt that it would be acceptable to their peers. And it often reinforced information that they had received elsewhere. Next slide. So having seen the potential benefit of a decision support tool, and in anticipation of new PrEP agents coming along, we updated the MyPrEP decision support tool to include information on the Dapivirine vaginal ring and injectable cabotegravir, and conducted cognitive testing with a range of stakeholders who really provided very useful feedback on the framing of the attributes, but also kind of the information and issues that would make it acceptable to users in that context. And as Connie mentioned, it is now being evaluated in Insight, but also there are plans to adapt the MyPrEP decision support tool for evaluation in a population of young men who have sex with men in Latin America. So we will see the kind of use, the value of the tool beyond the initial population in which it was evaluated. Next slide. And just to, sorry, no, you can keep on going. Sorry, Connie. Next slide, next slide. So really just, I think, to acknowledge the enormous contributions of all of the people who have contributed to all of this work, both from HPTN 084, but also the work with the team who worked on the decision support tool. And next slide, and then I'm going to hand it back to you, Connie, to close.
Great. Well, thank you, Sinead. That was great. And we just want to close by saying, I think hopefully our work highlights this, that we continue to believe that young African women are a priority for HIV prevention, given ongoing high HIV incidence in this age group and in this geographic setting, in spite of major strides in terms of testing and treatment uptake. We still need primary prevention for young women. Secondary prevention from scale up of test and treat is helpful, but not enough. I think through these various projects that we and others have done, we've learned a lot, sorry about the typo, about demand creation, integrated service delivery models, and the needs of users and providers. We didn't summarize all those findings, but hopefully we can, oops, what happened there? Oops, going wrong way. Okay. We have shown high uptake of PrEP and demo projects, but persistence is challenging. And I see there were questions in the chat about how did we recruit women? And really, it was pretty simple, like, are you interested in HIV prevention in community-based outreach? So I think the interest is there. If we can just do better at trying to help women make a decision, is it for them, so that we don't make them feel like they need to say yes on that day, that maybe it takes more time. And this is different than test and treat. We should give women the information and the space to make informed decisions. And we have to really try to understand why persistence has been challenging. We know that a pill a day is not easy for many people, particularly for youth, and we need other strategies. We also need to understand the populations where we're working. I hope people took note of the fact in Jen's presentation how depression and IPV rates are very high, and this was not a unique finding in the PrEP-SMART study. And so we may need to take a deep breath and learn how to address young women's mental health needs, as well as their biomedical HIV prevention needs. And I know that's work that Jen and others are working on. We have a epidemic, truly an epidemic of curable STIs that cause a lot of morbidity in this population. And young women do care about it. They're very interested and appreciative of the diagnostic testing through PrEP projects. Now we need to scale that up and figure out what are the most affordable and feasible STI diagnostic testing. We have to move beyond a reliance on syndromic management, and we need other interventions for African young women. And I think we need to accept that it's not that oral PrEP is not a feasible option. It is for a subset of women. I think some of the data from Insight highlight that, and it may not be, we know we didn't expect it to be an option that would work for all women, but for some that it is an option, and we need to help support them in their use of it. And then we're very excited about new PrEP options, including CAB-LA and the dapivirine ring, which we think, they are rolled out, could increase coverage, and coverage is what is needed to have a population level impact, as well as effective use, because they'll be less burdensome to users. So with that, we'll close. Sorry, we tried to put a lot into this. And I don't know if I couldn't do both chat and advancing slides, but I'm just scrolling through. Looks like Jen kept up and she answered hers. Recruitment, I tried to answer. I think in terms of the high adherence that we're seeing so far, preliminary data, admittedly, from Insight, it could be a white coat effect. A sub-study that Nicole Puvin and Sinead are doing will compare it to DBS, so we'll see whether it's white coat effect. I find it hard to believe it's, yes, there's probably some white coat effect, but I don't think it's gonna totally change the results. And what else? So I don't know, Sinead, do you want to take Jack Bresley's question about barriers to doing research with adolescents versus adults?
Yeah, I think what we've learned from doing research with young people is that they definitely require more support and input. I think, we underestimate sort of sometimes how that developmental stage means that they are going through a stage. And so, kind of things like finishing school, deciding where to kind of go to college, moving house because your family kind of uproot you. All of those things are things that make it more difficult for young women to practically engage in research. Their experience of the health system is more, they've had less experience. So there is just time spent supporting and educating them. And there are sort of the regulatory requirements, particularly in some settings in sub-Saharan Africa, where sort of young adolescents under the age of 18 really need parental consent, and that can be challenging, particularly if it means they have to sort of divulge their sexual activity. So there are a number of challenges working with young people. Having said that, it's a very kind of worthwhile experience, because I think that and I think it is feasible to do this work if you know these issues and are able to kind of plan for them and have the right staff on board. But I think sort of the opportunity in working with adolescents is also that you have a real opportunity to make a difference in some young person's life and establish habits or insights that may sort of last them a lifetime, build engagement in the health system at a time that sort of really makes a difference. And I think some of the data that Connie showed suggested that these young people stayed engaged with us throughout COVID, because we, the study provided support in ways beyond sort of just PrEP. So I don't know that answers your question, except to say it's a challenging population, but also a really rewarding population to work with.
Thank you.
So
Sinead.
there are more questions, and we will share the chat with our presenters, so you just know what else was asked. But before people start dropping off, I just want to thank Dr. Velosa, Dr. Kellum, Dr. Morletway. Thank you for a wonderful presentation with so much data and raised so many good questions. And thank you for your passion and advocacy for doing PrEP the best possible way for adolescent women and young girls. So Thank you very much for the presentation. We did a save the date. The next presentation is June 5th. And with much gratitude to our speakers, we will sign off. Everybody have a great afternoon.
Thank you. Thank you all for joining too, and for your great questions.
Thank you.